Everyone, thank you so much for joining us on an evening with so much happening. It's really appreciated that everyone would take time out to join us for this talk on the expanded role of nursing in IDD care in the time of COVID. So welcome. My name is Ben Margolis, Dr. Margolis. I'm a neurologist and psychiatrist specializing in the care of adults with IDD. And I'm part of the AADMD's COVID work group, so I am very honored to have been asked to host and moderate this discussion. I'm just going to take a quick moment to introduce the reason for the discussion and what we're going to be talking about. So, of course, COVID has rocked our world, and it's been a real testament to the skills and the capability and the innovation of the field of nursing, as in the IDD world, they've stepped up to bridge the needs, the medical needs of the individuals with the actual care on the ground. I'm so sorry. Thank you for telling me that I'm breaking up. Am I still breaking up? Am I still breaking up here?
Ben, you're not breaking up on our side, so it could be a bandwidth problem on the viewer's end.
Okay, thank you so much. I saw a notification that I should pause, but I guess that was one of the attendees. Thank you. So nursing as the glue holding together the actual on the ground care of the individuals that we serve and the medical needs of the individuals has been an enormous challenge in the time of COVID, with shifting regulations, with unbelievable logistical challenges, with constantly shifting and changing needs and guidelines. And nursing, at least in our end, in New York, I've seen accrediting the agency I work with, the Access Supports for Living in the Hudson Valley. Our nursing team developed protocols for the overall care of and protection of staff and individuals with COVID, in addition to caring for them while they're sick, protocols for monitoring them when they come home. And some of those guidelines were included in the AADMD's white paper. Sorry? On the AADMD's white paper on COVID that we just released 2 months ago. So, and that was developed by Naeem Korsa at Access Supports for Living at the agency I work with. So that's exemplary of the kind of work that nursing has been able to do. So what we're going to do tonight is to talk about the COVID specific roles that nursing has taken. We're going to present 4 sections. We're going to present the role of nursing in prevention and monitoring of COVID in the IDD world, in the management of individuals with COVID, especially in congregate and residential settings, the role that nursing has played in recovery from COVID. We're going to be talking about the unique challenges of arranging discharge and the step down from acute care that nursing has been able to meet. And then we're going to talk about a little bit about the role that nursing has been able to play in coping with the unbelievable stressors, both physically and emotionally with COVID-19. And then hopefully there will be time for questions. I'll just be interjecting and introducing the different sections, but otherwise I'm honored to step out of the way and allow our panelists to introduce themselves. And thank you so much for joining us.
All right, I've been asked to be the first to introduce myself, and I would like to say hello to all of you that are listening in to this webinar, and hope you'll ask us lots of different questions. My name's Wendy Nehring, and I'm Dean of the College of Nursing at East Tennessee State University. Over my career, I've written a lot and done research on topics related to persons with intellectual and developmental disabilities. And so I'm honored to be on this panel with all of these other prestigious nurses, and I will certainly lend my expertise as I can to this panel, but truly these other women will give you lots of wonderful information this evening. Thank you.
Well, hello, everyone. My name is Diane Moore, and I'm the Executive Director for the Developmental Disabilities Nurses Association. I've been a registered nurse for over 37 years, shocking to me as well. And over 30 of that, I've worked in the specialty of intellectual and developmental disabilities. I'm certified in the specialty of IDD, and that certainly is my passion. As I mentioned, I currently serve as the executive director for the DDNA, and I'm also a co-owner of a provider agency in the Dallas area for individuals with intellectual and developmental disabilities. So I'm honored to be a part of the panel tonight and look forward to hearing what all of my colleagues have to say. So thank you.
Hi, thank you for giving us your time tonight. It's my sincere pleasure to participate in this webinar. My name is Chris Helfrich. I have had the opportunity for the last 21 years to work for DD Homes Network, which in Illinois is a non-profit organization that's supporting adults in group home settings across our state. So a lot of the roles and job duties that I have varied anywhere from full-time primary nurse to designated group homes to currently working in the training department. I'm also currently serving as the secretary on the board of DDNA, so working a lot with Diane and the rest of the team. So happy to be here. I think in general, outside of being a full-time nurse, with the acknowledgement that I'm a proud don't know it all and a lifetime learner, I'm very grateful to collaborate tonight with DDNA and AADMD for tonight's webinar.
Hi, I'm Sarah Ailey, and I really thank everyone for coming and participating in this. I'm also very happy. I am a member of DDNA. I'm also certified developmental disability nurse. Very happy to be collaborating with my colleagues from DDNA and with AADMD on this panel. I'm a professor at Rush University College of Nursing. I was going to say, I'm only whatever, but I've been there since 1998. And most of my work with students and other, professionally, both research and other things that I have some grants, is in intellectual disabilities. And in full disclosure, I have a 44-year-old son with intellectual disabilities who lives in a group home in the Illinois area in Illinois. So, and I'm really happy to be here tonight. Thank you. And was I the last one? I guess I was. Okay.
Hi, this is Alan Wong. I'm just sneaking in right here to say hi to everyone. Thank you all for participating in this very, very useful and informative seminar. You may not know this, but I spent 4.5 weeks just last month out of ICU with COVID, and all those times when I'm there in those countless hours, I'm thinking to myself, how can our friends with IDD go through this? It's a tremendous, heart-wrenching, emotional, physical, draining kind of thing. So nurses, you have always been on my top shelf in terms of heroes, and for this population even more so. It's so important for us to keep them out of the hospital. So I am looking forward to seeing and hearing things that you're going to share with us. And I just want to see our member Ben and how dapper he looks, and how embarrassed I am with my outfit. But thank you, DDNA, for always being in the forefront of taking care of our patients. So I'm looking forward to seeing things. That's all you're going to see of me. Thank you. Thank you for the great work you do. And again, Sarah, congratulations on the recent grant. So good job.
Thank you.
Take care.
And for those of you who do not know, that was the president of AADMD, Dr. Alan Wong.
Wonderful.
Oh, yeah, that was.
Sorry, Alan, I didn't mean to speak over you. Thank you so much, Dr. Wong, for joining us and for saying hello. And we're just so universally grateful that you're recovered so well and back. And thank you for joining us. I don't know if forgive me for pointing out that Alan actually joined us from the ICU to participate in the last COVID panel. So talk about unstoppable. Thank you. So with that, I think we can talk about, we can begin the first panel, which is about the role that nursing can play, the key leadership role that nursing can play in the prevention of COVID and monitoring for COVID, in DSP training for PPE, cohorting, home testing, implementing safe practices in residential settings. It's a robust topic, so please.
Sorry, I had muted myself. Well, this is Diane again, and I'm going to kind of get the conversation started, and then I really want to open it up to the other members of the panel as well, because I'm certain that they'll have some great information to share. I think, as Ben mentioned early on, and maybe COVID has really highlighted more so than maybe some provider agencies or administrators were aware previously, but nurses do really play a key leadership role in managing health in general for the individuals that we support, and certainly trying to manage the impact of COVID-19 in residential settings, and also support individuals who are living at home in a more natural home setting with either parents or family or unrelated companion care providers. So really trying to provide that support and help folks kind of navigate through COVID-19. Obviously, we're all aware of the challenges, but I would tell any agency out there that your nurse is probably your best resource in terms of trying to help the agency navigate through that. So your nurse comes with, the understanding of disease process and infection control principles that other members of the team may not have. And so they can certainly help work on and help the agency develop a meaningful and practical plan for the agency itself. So my suggestion to administrators is, if you've got a nurse on duty somewhere, use them. And I think you'll find that they'll be most helpful. One of our primary responsibilities, of course, is educating support personnel. And as we move into more and more extended settings, much of the care for the individuals really falls to the direct support professional. And we're depending upon and counting on direct support professionals to really be, to know the individual, to be skilled at observing and reporting and illness, and we depend upon that in just kind of normal times. But in COVID-19, of course, that the need for that is even greater. So one of our first responsibilities as nurses is always to make sure that the caregiver is adequately prepared. And so providing that education, I think, is the first step in that. And all education, really should begin with kind of establishing or providing a foundation, and then you build upon that. And training for COVID-19, I would tell you, is no different than that. And so the first thing I think, is to make sure that people have a clear understanding of basic infection control practices, and then provide that initial education about what is COVID-19 and how is it transmitted and what can we do to try to limit the transmission. And I think those things are always important, and obviously including whatever strategies that the staff need to employ as it relates to observing the individuals for signs and symptoms of illness of any kind, but certainly of COVID-19, and then what those next steps are. Who do I call? What do I do? What steps do I take to try to limit the exposure to other people until this can be more completely evaluated? I think one of the biggest challenges that I know myself that I'm facing is, or all along through this, is kind of keeping it fresh, if you will. We're all dealing with somewhat with kind of fatigue over the whole concept of COVID-19. And so trying to keep that information fresh to both direct staff and managers, because I think there's, people get a little bit desensitized. And if you just leave some more information at the group home, or, try to have some sort of staff meeting and they feel like they're hearing the same information, a lot of times you lose them. And I think we see people maybe becoming a bit desensitized to what's going on, and maybe they're not staying on top of those important strategies as much as they were initially. So trying to find a way to keep the training and education fresh and make it mean something to them, make it relevant to them, give them data and information that lets them know that it's important for them and for the individuals that we're supporting. So I would say that that's one challenge that I'm facing, and I don't know about my colleagues, but just trying to make sure that we keep that the information and education fresh so that people that they really can embrace the interventions and the strategies and own some of that and really implement those things the way we need them implemented. Another huge concern from a nursing perspective is that what is developing that plan? What are those strategies? How are we going to manage this? How are we going to prevent COVID-19 from coming into our programs, hopefully, or what do we do in the event that COVID-19 does come in? And so again, larger provider agencies, a lot of times they'll have risk management departments or safety offices, and they may generate their own safety practices. And that may be a little bit easier because then, the program or the home really just has a set of practices to implement. But in your smaller agencies and smaller settings, oftentimes the nurse, people are really looking to the nurse to help develop those practices because they're the person with the expertise in the program. So DDNA does have some guidelines on our website for kind of helping walk through that development of a pandemic plan. What are some things you need to consider? What are some safety precautions? How do you cohort people in terms of people with infection or suspected infection compared to people that don't have any infection or any exposure, and then you may have that group in the middle that may have had some exposure but don't have any signs and they're negative on testing thus far. So a lot of times, again, looking to the nurse to help guide them in how they do that, and those strategies can be very difficult to implement. The planning can be quite difficult, especially if you're talking about a small group home. And if you look at cohorting in particular, most group homes don't have just an extra bedroom and bathroom handy that we can set aside and use in the event that we need to isolate or quarantine people. So really trying to be creative and think of ways that you can safely cohort groups is one of the key strategies, and your nurse is going to be really helpful, I think, in guiding you on that. One thing that I think, I don't know about other nurses, but I think a lot of nurses are struggling to keep up themselves with the information. And so having the time to research and keep up with what the new guidelines are from CDC or NIH or whatever, or their state regulatory agencies, that can be quite overwhelming when you put that on top of all of the other responsibilities. So one thing that I think we all need to understand is that some amount of time needs to be devoted to that. A nurse is only going to be able to offer as good of information as he or she might be aware of. So we have to be educated ourselves, and finding time for that is important in the planning process initially, but also as we go along, so that we can update those plans and strategies, and so that we're in keeping with the newest information out there. Again, one critical need that I think all nurses are facing is a way for our direct support personnel and for our nurses to really monitor for the emergence of signs or symptoms of COVID-19 among otherwise healthy individuals. And so putting in a system so that there's a way to be monitoring for that, having direct support staff monitor temperature and ask the individual if they have any, do you have a sore throat? Are you feeling okay? Do you have any fatigue? Some of those ways that direct staff can, on a, maybe once a shift or whatever, purposefully observe the individual, and then certainly report those things to the nurse. One challenge that I think nurses oftentimes face also, especially in smaller agencies where the agency is looking to the nurse for all the answers, and yet a lot of times the nurse himself or herself, they don't have experience in writing policies or protocols. So again, I want to encourage them to go to the DDNA website if you're looking for, okay, how do I make sure we have a plan that's going to address most of the things we need to address? There are some guidelines there. And I think I forwarded to Courtney, but a screenshot that can kind of show you that. But if you'll go to ddna.org and you'll log in and then click on, I think it's the tab is information, if I'm remembering correctly. And you'll see a drop menu that has a whole section there for COVID-19. So you'll see those guidelines there. DDNA is also, thank you, Courtney, also going to be updating those, and those will be coming out in the coming weeks. We just don't have those out and ready to go yet. In addition to that, there's a whole list of other resources from other entities outside of DDNA, but great information. So again, if you'll log in, you'll be able to just scroll down and tap into resources from across the healthcare spectrum. So I think that those are the first things that I would say if we talk about planning and prevention. And lastly, I guess one thing that I think we all can acknowledge is I think one of the challenges in supporting people with IDD is a lot of times the living environment for the individual. And interventions that really can be quite simple in a typical home or normal, just kind of a residence. Those are anything but simple when you talk about trying to implement those in a group home setting. And so it's important that we understand the individuals that we're supporting in that home and also the limitations of that support setting itself. I think being prepared to be flexible, because what might work in one place might not work in another. And being prepared to think outside the box. And that's a term I really don't like to use, but it is what I think we have to do every day, quite frankly. And if you talk to most DD nurses, that's what they'll tell you, that every day is a day of, okay, how can we make this work? Because things that might work in other or more typical healthcare settings might not work in a setting for IDD, and yet the need is still there, and the nurse still has to determine or find a way to make that, to address it and to make it happen, as it were. So, I think unfortunately COVID-19 obviously is not going away anytime soon, and so preparing for that and preparing kind of for that long haul. And I think, the individuals that we support, they are ready for their lives to get back to normal. So in that planning process, I think including the individuals as much as possible is important, and including those stakeholders to get people to first of all, to get their input, and secondly, to get everybody on the same page and kind of ready and prepared to do what we need to do, and kind of buy into that, if you will. So one question that we talked about, I guess, was how can nurses in general be better supported in their role? And so that was a question that was kind of posed to us of how what does a nurse need from the administration or the managers? And I think, first of all, everyone to understand that this is still an evolving situation, and expect it to be so. And it will be fluid. And so understand that everyone needs to be flexible. But I would say, in terms of how can we better support one another and how can we better support nurses, just offer that support, check in, ask, listen. I understand that most of the time nurses take the responsibility of ensuring people's health and safety very seriously. And so, you know, when the situation is so out of control, where no one has control, it weighs on you, and it certainly there's a mental toll that I think is taken. So just understand and listen, to be, you know, provide a way for them to vent and then help problem solve, because sometimes the nurse may hit a wall and go, I'm not sure what to do here. So here's what needs to happen. How can we make that work together? So those are some suggestions that I would have. And I would like to just open it up and see if the other panelists have some things they'd like to contribute as well.
So Diane, I thought of a couple of things while you were talking, and one of them, when you were speaking to the question about how the agencies can support the nurses, I think that with the time involved that nurses are spending to train DSP, to monitor individuals, that there's almost a need to shift some of the responsibilities. Though many of those things that nurses do are tasks that can't be duplicated by another. We recognize that, and we certainly don't want to give away that responsibility. But I think that if we really look at all the work the nurse does throughout the course of the day, that we could maybe trim away a little bit of time from something, maybe coordinate training so that instead of in a larger corporation, each nurse doing their own training of the DSP, that maybe there's a centralized training mechanism that's put into place. So that's going to give back to that nurse 8 hours of time that she, you know, had previously scheduled for doing a class. So I think that that might be helpful. And I think one of the other things that I know that we've tried to do in our organization with our nurses is to provide an open forum option for nurses to jump on a webinar, check in with one another, just as you said, and for us to just be able to communicate with one another. And I think that that has been very helpful in sharing of ideas and making sure that we're not recreating the same wheel, and sharing resources with one another. So those are a couple of the things that I wanted to add to that.
Great, thanks. Wendy, do you have anything you'd like to add?
Sure, I'll add just a couple of things. You gave a lot of great information, but one couple of things that I was struck with is I was thinking of mask mandates and the like, and how it's difficult when you're an agency, depending on how your state is reacting to the guidelines. And so, for example, I live in Tennessee, and our governor has said that it is up to the county mayors to determine whether or not their county will have a mask mandate or not. So our county mayor is certainly doing that, but they're not enforcing it if you don't. So certainly a lot of people don't. And so it's important for the nurse to say, these are the guidelines. This is what the scientific community has said is important, the medical community, and this is what we've got to do. And whether or not you want to believe it in your own personal time, what you choose to do, but here at work, this is what we're going to do. So sometimes that comes in conflict, and it's just a matter of using the science, as we've been saying, and following through on those guidelines. And the other thing I just mentioned is, on the topic of prevention, I did not mention in my introductions that I am on an operations board of a nonprofit organization in town here for adults with disabilities. And today we had our board meeting, and one of the things they were discussing was the fact that the holidays are coming up. And over this whole time since COVID started, the agency hasn't allowed family members to come into the group homes, but they're getting restless. And as Diane said, we're getting tired of this. And so with the holidays come up, they're going to loosen up a little and let the residents go to their family homes for a weekend or maybe for a week, depending on what the plans are. So they have proactively put together an educational packet that they're going to send home with the relative, or with the resident, I should say, talking about, just as Diane had said, the guidelines, the symptoms, all the things that she spelled out there, and are going to send it home, and they're crossing their fingers and toes that no one comes back positive. So, you know, we've been reacting to everything we hear, but now is an opportunity to look towards the holidays and some things that we want to prevent, hopefully, in doing these different things as we go forward. And I know in Tennessee, our infection rate has gone way up.
Yeah.
And so it's just important to continue to be mindful.
And this is Sarah Ailey. I was going to say also that education piece is not only to the residents and also to the staff. Okay, you need to be wearing a mask here in the group home, but pay attention to things like you should stay out of large social gatherings. Maybe you shouldn't go to the bars. You know, you need to protect yourself off-site as well, and that's a whole piece. And I think, I mean, we all know that under COVID, telehealth has come in. A lot of things are going on online, Zoom, as we're doing tonight. And certainly a way to then, for nurses to work with a group of DSPs, because they could all be at home or somewhere else, but you can, you know, you can do training, not in person, but virtually. So, and that's not going away after COVID. We're not going back to the way we used to do things. There's going to be a lot more in the way of virtual education in all settings. More people work, you know, so we should take advantage. We need to take advantage of that aspect of COVID, of being able to use those kinds of technologies.
Yeah, I agree with that. And I thank you guys for your additional comments. I think all of those are spot on. And I do think part of the training, I know certainly that I do, but to your point, Sarah, I do think, again, as I said, I think we have to, when we do the training, we have to make it meaningful to the person, and it has to be relevant to them. And so part of it does have to include that very subject of, you know, fine, here, when you're here, this is what you're going to do. But when you're away from here, how are you keeping yourself safe? And Wendy, to your point about the holidays, I know we're struggling ourselves because we're looking at, okay, how do we do this? And we're looking at, you know, is there a way to kind of isolate, if you will, in group when people come back, you know, designate certain parts of the home as people who've, and while that in some ways kind of flies in the face of infection control, you know, one person may have had completely different exposures than another person who was gone. We're trying to find some way to certainly allow people to do this safely, because it is becoming more and more critical. And we're certainly seeing some mental health stuff, and Sarah's going to share on that. So, but we're seeing some of that as well. I think most people are. They're ready for their lives to begin again. So. So that's kind of the few thoughts I had. Ben, is there anything that you need to share before I kind of turn it over and let Chris take on the second section of this?
No, I think that's perfect. We just wanted to point out that the AADMD has, at the end we'll mention, but the AADMD in addition has some guidelines on cohorting that we're starting to get toward, which is another key part of prevention, and the next two kind of main topics we'll tackle. And I appreciate that we've had some previews to some of the other topics as we talked about telemedicine as a tool, and as we talked about some of the problems of management and training and making sure that it's relevant. So Chris, do you want to start talking about the management itself of COVID-19 and challenges that nursing has been able to tackle in stepping up to this?
Sure. So I think what I'd like to start off with is, you know, what happens when an individual develops COVID-19 or associated symptoms. And essentially here, what we're looking at is that, you know, nurses are the profession that are trained to recognize correctly the individual's existing needs, as well as recognize potential needs or risks. So in relation to what nursing can do with COVID-19 symptoms with our individuals, is just approach those care needs in a formal fashion with step-by-step approaches which essentially is our nursing care plan. And with this care plan being a foundation of communication with staff, as well as other management personnel or other caregivers, each step of the process can certainly be designed to indicate the persons that are going to be responsible, so that everybody seems to be working from the same page for the common goal of recovery for the individual with COVID-19. And certainly the care plan should be updated throughout that recovery process as the individual is progressing, or perhaps there's changes in their condition, and also recommended that this plan of care throughout the course of illness be evaluated by the agency's quality assurance committee, so that if globally there needs to be some changes implemented in policy or procedure, that can be addressed. So if we've got a care plan that is implemented and we're seeing that there's holes in the tent somewhere, then we can circle back and kind of reevaluate that and maybe update that plan of care. So moving forward, we're utilizing that information to provide better care for our individuals. So I think one of the biggest challenges that our DD nurses will have is devoting adequate time to educating the DSP. And Diane, you kind of spoke to that a little bit. And my input there, my thoughts anyway, were that, you know, if we can trim away some of the tasks that the nurses might have taken on over the course of time before COVID, and give them the resources and the time to devote to that training, I think that would be ideal. I am pretty confident that the method of training is important as well. So when we are connecting with the DSP, we need to do so in a fashion that's not only going to keep them engaged, but also is going to resonate with them as something that's going to stick. And we're not going to do that if we type up a form and leave it plastered on the wall of the break room, or maybe the medication room. So if we're taking that approach of in-servicing our staff or training our staff by giving them something to read, it's probably pretty evident at this time that they're not going to read that. So we're looking at other resources, utilizing webinars, for example, so that we can reach more than just one area of DSP, and kind of coordinate that time that is consumed with the training. But also to make sure that the nurses understand that training also can just be working with the staff. Just a quick story share. We have a nurse in our agency that I work for that described her experience with caring for COVID positive individuals as challenging, but not in the way of effective staff training, but the staff response, knowing that they were going to be caring for someone that was COVID positive. So earlier in the time of the pandemic, when less was known about COVID, the staff essentially conveyed to the nurse their genuine fear of taking care of these individuals with COVID-19. And she recognized this as a deficit to any further training. The staff were terrified. They did not want to come to work. So she actually just changed shoes and put on her PPE and came to work. And she actually worked side by side with the staff for the first couple of days. And she worked with them on just the simple, well, we might think of it as simple, but not for the DSP, the order of putting on their PPE and the order that they take it off. And she worked with them on that. She demonstrated how they could coordinate their care. So when they did enter that isolation room, that they were able to accomplish several tasks at the same time. So it would minimize how quickly we were burning PPE. And it would help the staff to recognize that, yeah, I can do several things at the same time when I come in the room. So I think that experience and her sharing that with us was very helpful to know that the nurses really can't take a back seat, sit in the office behind the computer, and have, you know, an effective training or management system in place for our folks that do have COVID-19, that we actually need to be in the homes. We need to see, you know, what kind of deficits we have in relation to the training compliance on the part of the DSP. I just think that story of the nurse that had worked with the DSP is something that I continue to see happen then as we are moving along in the story of COVID in our group home and community-based settings. In some cases, there's just simply not enough staff. And sometimes the nurses themselves are working, but I think it's, again, another great way for the nurses to kind of extract the information that they need to accomplish, those effective care plans and some step-by-step processes that need to take place. In addition to that, I think checklists are very helpful. So I would encourage that if the nurse can put together some sort of a checklist for the staff when they are caring for someone that's COVID positive, that certainly is going to be helpful. Individuals whose care needs exceed what the home can safely provide is something that the nurse is going to need to recognize and actively move forward with that necessary next step. So when our folks are dealing with the moderate and severe symptoms of COVID-19, the group home setting might not be the appropriate place for that individual. Their care needs are probably going to be supported throughout a hospital stay until they are more successfully recovered and they're stabilized enough that it's safe for them to come home. And I know that we're going to talk about a discharge and continuity of care there a little bit later, so I won't go into a lot of detail with that. I will pause and see if any of the other panelists have anything to add or jump in at this point.
Well, if it's okay, this is Sarah Ailey.
I saw you smiling, Sarah. I thought maybe I should hush for a second.
So I sometimes, because I'm in the sort of Ivy, covered towers of academia, but I am a certified developmental disability nurses, and what can we sort of bring? So what, we all have, actually we had a lot of stuff where I am, a lot of our courses were already online, but I had never done a virtual clinical in my life. So, one of the things we have access to is, people who do educational design. How do you make it interactive? I know Dr. Wong mentioned that we at Rush just had gotten a grant from Administration for Community Living. And one of the things we're doing, and we are working with somebody who does educational design, is we're working on designing telehealth visits with interprofessional teams with people with intellectual disabilities and caregivers. And I know we're at least planning to work with a couple of agencies that have group homes to set these virtual visits up. And it's really nice to have somebody who's into educational design on the team, because he can give us insight on how to do things that are interactive. And so that might be a good link, to link to some of us in academia. I've had to go take courses on educational design. They made us all take a course after COVID. So, so come pick our brains, what we've learned.
Yes, definitely. I think that's so proactive. And to that point, I think, that's the necessity that we are in right now, is if we don't know how to do a webinar or we don't know how to participate in a Zoom call, we better find a YouTube video that shows us how to do that, or talk to the grandkids. They know these things too. They can show us how to do this stuff.
Well, my 4-year-old grandson can probably show you a few things, but yes.
Exactly. So, I don't think that in my nursing career, I ever thought that I was going to need to have this much computer knowledge. But at this point, it's my responsibility, because if I'm going to be able to train and to work with the guidelines that we have right now, and I can't do this necessarily in person, I'm going to have to find another way to pivot. And that's my responsibility. And I feel like the individuals really shouldn't be asked to wait for us to figure that out. Time is of the essence here. We kind of need to get on the ball. And as you said, there's a lot of resources, a lot of classes that we can take to better ourselves, so that we can utilize that within our own agencies as well. Diane, did you have anything?
I just wanted to echo something that you said, and that is that depending on the condition of the individual, I think it's important to recognize the limits of the program or home in which the person might live, and oftentimes as people with COVID-19, as the disease progresses, they develop symptoms or conditions that really can't be practically supported in a small group home setting. And so I would encourage provider agencies to always ask that question first. And even when we get to discharge, you know, one of the questions is the person's, is their health status at a state where I can reasonably and practically support this person in the setting, you know, where they're wanting to come back. And so I just want to echo that I think that sometimes we get stuck in a mindset that we're to meet all needs of every person forever and ever. And sometimes people do develop conditions or levels of illness that require care in a different setting, in a more acute setting with more structure or more support.
Okay, thank you. So some additional thoughts that I had with relation to the management of COVID-19 in the group home setting would be to recognize that in most cases, we have to implement as close as possible to standardize things such as cohorting, isolation, and source control. So there are some things that we can control, like elevating the frequency of disinfection, for example. We might be working with a group home of individuals who have varied levels of cognition and ability to be compliant with things like safe distancing, with wearing of fabric face coverings and such. And with those challenges, you know, we might not be able to be very effective in making changes with that, but we certainly can elevate how frequently our staff are disinfecting. We might be able to minimize the number of staff that are taking care of the individuals that are COVID positive as well. So I recognize that in our group home settings, traditionally, we aren't overloaded with staff. We don't have people beating on the door asking if they can come work for us. And it is a challenge. And I say that with as much robust behind as I possibly can, because when we do work with our folks that are COVID positive, they're, you know, sometimes having an A team is really great, but then we need to think about what the outcome of that might be. So if I'm pulling a staff from a different home to work with these individuals that are COVID positive, then there's going to be a period of time where they can't work. And for some of our GSP, that's the difference between eating and not eating, and being able to pay their bills and so on. So you know, the types of decisions that we're making with regard to staffing the homes and caring for our folks that are COVID positive have real impact on the staff. So, you know, we do need to be mindful of that and be exercising good decision making when we're deciding how we're going to manage and balance some of those additional challenges. How are we doing on time so far?
We have a few more minutes,
Okay.
but I wanted to interject as well as moderator, just to Diane's point and to your point, Chris, about when an individual can't be managed in the home. Certainly, that's an opportunity for a transition to talking about recovery from COVID-19 and the importance of the nursing team as a liaison. That's really an opportunity for nursing to connect with us directly on the medical side, to be able to know when an individual can't be monitored, to always, you know, when someone is COVID positive, to be sure to be in contact with their medical, their primary care physicians, their pulmonologists, in order to know what the limits are and when to step up care. There's also information about some suggestions. Once again, I'm going to not to beat a broken record, but there's information about this in the guidelines that came out from AADMD that were inspired also by the nursing team and developed by the nursing team at the agency I worked with as well. So want to point us back to that. Thank you so much. I'll let the team take over again.
Okay, well, I have another thought too, and I think this might be relevant for some of us now with some of the regulatory agencies kind of reigniting their survey process and actually coming to visit us and evaluating how we're handling COVID-19 in our homes. But I think in general, regulatory agencies may indicate that their goals of survey during the pandemic would be that of education and to help provide the necessary resources for the agency to assist in maintaining the health and well-being of the individuals. But there's still a few surveyors out there that would evaluate the home's response of COVID-19 to be unsatisfactory in more of a punitive sense rather than an educational sense. So I think for those of us that have or will experience this, my encouragement is for us to stand up and be confident of the care needs and procedures and policies that the team and the nurse have carefully engineered that fit the needs of the individuals in their home. It's not going to be perfect cohorting. It is not going to be the most ideal isolation, but in many cases, we kind of have to just pivot and do the best we can with what we have. And I think that if there is an overlying fear of having a negative survey as a result of that, then we might at some point just have to be okay with that. We might have to certainly look at our policies and procedures and make sure that we haven't overlooked anything. But in terms of outcome, there's no way to guarantee our individuals are going to wear fabric face coverings. In Illinois, we've been provided a guideline that says that, well, if they don't wear a face mask, then try the face shield. And that was a guideline that was, just universally put out a couple of weeks ago. And those face shields are kind of clunky. I think that some of our individuals might be terrified of putting something like that on. So, certainly if our surveyors aren't understanding that we are doing the best we can with this population of individuals that have those extra challenges and the need for us to support them, then, we may have to just, do the best we can. By no means am I advocating that we toss out the window any of those rules or regulations that are established by each of our states. But if the square peg's not going to fit in the round hole, then we have to take the appropriate and safe alternative actions in those situations. So that was one other thought that I wanted to bring in there.
And Chris, that I did have that in my notes as well, that I think a lot of times for the people that we're supporting, I have a number of individuals where we're actually working on desensitization to try to help them tolerate that, especially, in the event they have to go out into the community or whatever, because some will take to that readily, but some won't. And so I think that, again, to your point, we're doing the best we can do. And if it's incredibly stressful to a person to try to require them to wear that, well, let's see if we can't help them develop a tolerance to that through some real desensitization training. So that's just a suggestion I would throw out there as well.
Yeah, and I do think that the desensitizing programs and those steps that we take, are things that we do have to, again, concentrate on training our staff. Because it's not a repetitive cue that we're asking them to repeat. The individual's going to get very frustrated very quickly with hearing someone say, put on the mask, put on the mask. That's just not going to work. But if we give them a structured program or structured steps, as I was talking about earlier, things that they can do, then maybe just having an individual hold the mask for a few minutes would be a great idea. Maybe having them personalize this fabric face covering with utilizing fabric that might mimic a sports team that they like or something. And I think one of the other things that one of the managers in the agency that I work for, she utilized a step in her desensitizing program for wearing of fabric face coverings that the staff initiate polishing nails. And this, of course, was with our female individuals. So they would get to the step where the individual would allow the mask to be put on, and they would instantly start the activity of doing nails. So you're not going anywhere with your nails. You can't pull that face covering off because your nails are wet. So you got to let those dry for a while. And then there's that opportunity where you've combined a program to desensitize with an activity that they enjoy, we hope. Their nails look gorgeous. Mine don't. So I probably could use one of those programs too. And you've got an individual then that you can verbally praise for having kept that mask on during that process, you know, and continuing that in a positive direction. Hopefully, you know, your individuals are going to get closer to recognizing that they can be successful with wearing those fabric face coverings. So doing something with the hands as soon as that face mask goes on that person likes, you have to make that connection, you know, that it's something that the individual enjoys. But that sometimes helps to expand that time frame where they're wearing that fabric face covering. So.
This is Sarah. I would note that there, among the attendees, there have been several resources that people have linked to. I hope everybody can see them. So from ANA, American Nurses Association training, some trainings from Wisconsin, webinar series that went on through Health Matters at UIC towards community-based organizations on managing COVID. So there's several resources that people are putting up in the chat box. I'm just noting that.
Okay. All right. So Diane, I'm seeing the cue that we're ready to kind of move on to that next phase.
Okay. Well, do you want to go ahead and start that, or would you like me to? We didn't test, did we?
Yep, we did not practice this, so we're just going to.
Well, the next section we really wanted to focus on was recovery from COVID-19. And so we wanted to look at what are some steps that we need to take when a person's been hospitalized or in the emergency room for COVID or for associated symptoms. So how does a nursing team ensure a safe transition back to the home? And looking at, you know, the same things that we've talked about in terms of cohorting and education of direct support professionals, et cetera. So I think the first thing that I would want to mention in that is that the nurse should be having ongoing contact with that acute care facility throughout the person's stay. So that, first of all, it's not a surprise, and also to communicate, as Ben mentioned, you know, some of the things that we would need to have in place or criteria that we would need to see met in order to be able to safely serve the person and have them return back to the home. So that ongoing communication between the acute care facility and the nurse, I think, is critical. I think the other thing that to try to get in kind of ahead of it, if you will, is to prepare in advance for some of the conditions that the person might be facing. They may have, they may need oxygen, for example, or they may need some real assistance with ambulation, whereas prior to hospitalization, they may have been completely independent in that. So being prepared for those kinds of things and having the resources either available or at least identified so that you can readily acquire some of those things that you might need when the person is ready. Obviously, prior to the person coming home, having some real discussion about the person's diagnoses or diagnosis. What are the, what medications, what are the treatment needs of the individual? What are their personal care needs? What are the isolation requirements, et cetera, so that you can begin educating people in the home, but also setting up the proper environment for the person. And then isolating the individual following your cohort plan, which is again going to include educating those direct support professionals about the isolation plan, about PPE, making sure that they're understanding what they're supposed to do when and how they're supposed to meet the needs of the person. And I love Chris's point about, teaching the direct staff that you don't have to, that you can complete a number of tasks once you enter an isolation area. So some of those tricks of the trade that nurses know just instinctively, or we've certainly learned over the years, but making sure direct support personnel have that information. And, fundamentally determining who's going to provide the care. How are we going to provide the care? Who's going to do it, and how are we going to limit their exposure to other people in the home and or other people in other homes, et cetera. So, and then clearly, that critical nursing assessment once the individual is returned. developing that nursing plan of care, identifying what the person needs specifically, and making sure that everyone has the information. Providing for, again, those changes that either in health or their physicality or their physical needs, making sure that those things are in place. And I think, depending on the acuity of the individual, nurse should be reassessing that person at least daily, maybe more often, depending again on the condition of the person. But that would be my expectation as the nursing supervisor or clinical leader, that a nurse needs to complete a nursing assessment at least daily and more frequently as indicated. And one thing I think that's real important too when the person comes home is that the nurse maintain frequent contact with that support staff. Make sure that we're asking the right questions, getting their observations, being responsive to their questions and concerns. And something that Chris mentioned, about the staff were terrified initially. The staff are going to have a heightened level of concern. And so we need to be there to provide accurate information, be supportive, provide calm instruction, and support, and try to alleviate some of their anxiety, because I think that was such a wonderful insight the nurse had, that until she can get beyond, help the staff get beyond their own anxiety, that teaching is really not going to, learning isn't going to happen. You can teach all day long, but until the person's anxiety is kind of at a manageable level, or where they're at least less anxious, you're not going to be able to really effectively help them learn how to manage the situation. So those are some first steps that I would throw out there. I think, of course, we can talk about barriers here in a minute, but Chris, do you have any other thoughts on kind of that initial what to?
I don't know that I have anything different from what you said. I think just to kind of dovetail on that communication certainly is key. And I don't think discharge planning for an individual with a developmental disability related to COVID-19 or not related to COVID-19 is any different. I look at that hospital discharge the same way now that I did before COVID happened. So I start communication at the time of admission. And my job at that time is just to make sure that there's some continuity of care, that they do have the basic information to know that individual's baseline, so that they know that when that individual is reaching out to someone, that's their way of saying everything's going to be okay. That's what he does to say hello to his staff. That's not because he's trying to grab at the nurse or grab at the technician that might be in his room. So I want to make sure that I'm communicating that right from the get-go. And then I maintain that rapport and communication with that hospital staff throughout that entire hospital stay. So they're going to see me or hear from me on a regular basis. And I'm looking for updates and reports. And it gives me an opportunity also to determine whether or not the hospital has a good understanding of where this person came from, because still in this day, we have a number of acute care settings that are receiving these patients in very ill conditions and not having an understanding that they don't live in a facility that has 24-hour nursing. In some of our states, some of these group home settings and community-based living arrangements don't require nurses. So, again, just cover all of those bases. I think communication is definitely key. And I think that the right person to be doing that communication would be the nurse. I do think that, some DSP probably call and check on individuals, but when you've got two nurses communicating to one another, you guys are speaking the same language and you have the same goal. Not that the DSP don't have, an interest in the well-being and the outcome for that individual, but I do think that it's very beneficial to make sure that those nurses are communicating with one another.
Agreed. Sarah or Wendy, do you guys have anything you'd like to add?
Okay.
Well,
so we could probably move on to those barriers then to safe discharge. So what are your thoughts about that, Diane?
You're welcome to go first, but my first thought was, establishing a quarantine area, and we've talked about some of this already, assuming that that's necessary, identifying where and setting that up, especially again in those small group settings, and then providing again adequate trained staff to meet that person's needs. You mentioned something that I think has become even more critical with COVID-19, and some of it is our staffing considerations and concerns. Providers across the country are struggling, and as you mentioned, nurses are working direct shifts just as a direct care provider because there are not enough direct support professionals to go around. And I know just in my agency, we've lost a number of people because either when schools closed, they no longer had health care for their children. And so they were not able to work. Many of them have children themselves that are, very vulnerable. And so they're concerned about exposure and taking that home. And so we've lost a number of staff to that. So I think that is the challenge and it's certainly more difficult today than it has been in years past. So one of the challenges as it relates to discharge from hospital is, ideally you would have a separate set of staff that provide the care for individuals that are in a quarantine or isolated kind of situation, and not utilize those staff, not only with the other individuals in that home, but not have those staff work across programs. And so that the limits to staff availability is really a huge challenge, and how to manage that and really keep people safe is very, very difficult right now. Very difficult.
Yeah, I would put an exclamation point to that, Diane. I know in my N of 1 with the agency I'm affiliated with, the staff turnover, whether it be nurses or direct support professionals, has gone up, and you just can't replace them. So, you think about what incentives could we do as a board to get people to come in, but then when you don't know if there's going to be a budget cut somewhere down the line, it's a catch-22. So yes, thanks for mentioning that.
And then, if they have exposures, and, one of the things, of course, that we do with all of our staff at the beginning of each shift before they're permitted entrance into the home or what, is we screen them for, signs or symptoms, but we also ask about any exposure. And so if you have people that have known exposures, then you go, okay, well, okay, then no, you can't work today, and and you're going to have to be off until whatever. And so navigating that is very difficult, and quite frankly, that I think is something that certainly consumes a lot of my time. I don't know about you, Chris, but is working through those individual issues or incidents, and really being able to come up with a safe solution. How long does the person need to be off? Do we just have a test and say it's okay? What do we do with that? So I think the staffing crunch is probably the most critical thing we're facing right now. We just simply don't have enough people. And I don't, and to Wendy's point, you do sit and you try to come up with, what could we do to incentivize? How can we, how can we reward them in some way in addition to what we're doing? How can we demonstrate our appreciation? And so we are working to do that, but that is the critical issue, I think, facing all of us right now.
That's a perfect transition, because how can we support staff? And that's a great point to start to think about what nursing can do from a leadership perspective in helping staff, families, individuals cope. So, Sarah, if you...
Myself? Yes, I'm talking about managing stress and anxiety related to COVID, particularly caused by what we all face. And it's so well put by a person with intellectual disabilities who was interviewed on our local PBS show, Chicago Tonight. And I'm paraphrasing what he said, but he said, we want to see our family and friends and we want to go back to work. And that's pretty much true for all of us. And so the question is, how do we engage in our lives and live well as much as possible during COVID? There are good ideas out there on how to help. I did see in one of the chats that Terry Broda had posted some things from the UK. Another example is Surrey Place in Ontario. They've done a good job, I think, of having links to many resources on their website, including how to manage corona and virus anxiety. I myself went to one of the meditations. It was just the right length. And doing things like telling social stories or working with people on their social stories about what the isolation is like, to links to things like how to do exercise and crafts and these kinds of things at home across the lifespan, from children, toddlers to senior citizens like me. And so that, I think, is all very important. I would say that, I was gonna say, when I starting at Surrey Place, I found links to lots of stuff, crafts, exercise, meditation techniques, and so on. And those have been shared, on the screen. So I lead the DDNA Education Council, and we've discussed these materials and shared them around. And so the focus here is a little different than managing COVID, which the other speakers have talked about. The focus is, how do you live well despite COVID, or at least during COVID? And I think with their day-to-day connections, nurses can lead efforts to sort of operationalize and tailor the types of activities that you can find on some of these websites to the communities we serve. So to do things like help clients keep in touch with families. I know, talking to a couple of agencies here, they're buying like smart TVs so they can use them for things like Zoom or whatever, visits with family members, or telehealth, in their large screen. How do you connect virtually to day programs and recreational activities? I know my son here is in a therapeutic recreation Special Olympics program, and they were having a 2 or 3 hour session every day that had activities and exercise and so forth. And he lives in a group home. They told me he was actually participating in the stuff. So I was impressed with that. There are these kinds of things are being done, and finding alternative activities to what people may have been doing during the day, such as crafts, assisting with cooking, learning a new game, doing things to get some exercise, and certainly using stress techniques, relieving techniques like meditation and deep breathings. And certainly nurses are then in a position to also assess for clients who need more than general wellness activities, who might need additional mental health services. And they certainly can work with and train the frontline staff on how to support the clients in these activities, but also help in reporting signs that someone may need more intensive mental health support. So that's kind of briefly what I think some of the issues are, but I do think we need to work on leading the independent of COVID. And as we go forward out of COVID, we need to work on leading development of wellness plans and living as well as we can with whatever health conditions we're facing, and certainly as well as we can during COVID. So those were my remarks, and just open it up.
Well, one of the things that we've done, we've always had kind of resident council meetings or home meetings or whatever. But I have instructed my staff that part of those meetings that we have, and we have them at least monthly, but we talk about kind of the what and why of where we are today. We remind people just kind of, as we all know, and we give people an opportunity to really share how they're feeling about it. Sometimes we may need to provide a little bit of prompting about, have you talked to your sister or your brother or whatever, how are you feeling, but give people an opportunity really just to kind of talk about how they're being impacted. And I think that a lot of, all of us need to know that someone is listening and someone cares. And so giving them an opportunity to talk about that. And then also to try to elicit from them some ideas that they might have about things that they would like to try to do. And sometimes we certainly have to go, well, that'd be great. We'd love to go to the XYZ, but unfortunately we can't. So let's think of some way we can do that here in the home or in the backyard or whatever. We, very, very individualized homes. So, we've got one group that we're regularly purchasing some sort of sporting pay-per-view event thing, whatever, and it's wings and pizzas, and we have a pay-per-view event as something kind of special. Another home has started a quilting project because there's a staff person there that loves to quilt. And so they're all working on a group quilt. We've got another home where they wanted to plant a little garden outside. So trying, again, like some of the things you're talking about, learning and embracing some new things that maybe we haven't done before, but that maybe something new and become a new passion for somebody. So those are the things. And then of course we're trying to facilitate communication between the individuals and their families, video calls, phone calls, letters, that kind of thing, crafts, so that they can make something and send to the family, that kind of thing. So those are some of the things just to try to continue and to let them have the connection with the family that they're accustomed to having, and trying to promote a sense of still feeling that connection. So those are some of the things that we're kind of doing. And to your point about some of those resources are great, Sarah. So I appreciate you finding those. And just from my nurses are certainly trying to make sure that the direct staff remember that COVID-19 is affecting everyone. Right. Everyone is being affected by this, and the individuals that we support are being affected as well. And to really kind of be mindful of that, even if the person doesn't communicate in more traditional ways, and maybe even especially, or perhaps more so if they don't communicate, but look for some of those signs of anxiety or depression, and that they may be coming out a bit sideways and not in a way that you might typically see, but trying to make sure that direct staff can be aware of that and communicate that to nursing staff, I think is important as well. So.
And I know that, for instance, in Illinois, because all the day programs were shut, and at a certain point, the state said, well, you can't, we're not just going to pay you 24/7 for SILA placement. You have to do day programming during the day, which was certainly, considering the lack of staff and so on, certainly a challenge. But these kinds of things, that, okay, let's learn to do something different. Maybe you do have a yard. You can go out and plant a garden there with the people who are able to do that, or do crafts. So those kinds of things you mentioned. And certainly it has to be tailored to the particular home and individuals.
So with that note of recovery and health, we have 5 minutes set aside to just point out if there's anything that the nursing leaders here can offer to non-nursing attendees for what we can do just in the world to support our nursing colleagues through this COVID time. If anybody has any thoughts, we've got 5 minutes. Otherwise, we can go right into a Q&A.
Well, I would just like to say the one thing I think is for people to understand the mental fatigue, the practice fatigue that I think nurses are facing. All of us can tread water for a while, but when you have the ongoing focus and the attention to detail with every situation, as you know, that's required, it really is fatiguing on so many levels. And so I think our nurses are feeling the stress. So we try to provide the education and the reassurance that does reassure other people, but at the same time, we ourselves are I think some of us are struggling a little bit with practice fatigue. And I mentioned earlier that nurses, I think we feel a tremendous responsibility to help keep people safe and healthy. And with so many variables and so little control over this situation, I think that sense of responsibility, it really can be overwhelming after a while. So again, my suggestion earlier was, just have a conversation, check in, ask people how they're doing, understand and help problem solve, because sometimes that's really what we need. We may be hitting a wall ourselves and out of all ideas. I've exhausted everything I can think of, help me figure out a way to do this. And something Chris pointed out is some of those things that nurses end up taking on, because we tend to kind of do that sometimes, where we go, okay, I can do that. Oh, sure. Yeah, give me that. I'll take care of that. And so for nurses to kind of stop for a minute and say, okay, what are some of the things that I've taken on that maybe I don't have to do? And for administrators to really strongly encourage them to do that. Because sometimes we still persist even beyond the point that's healthy for ourselves. So those are the couple of things that I would suggest, and I'll mute my microphone now. Thank you.
That's actually pretty much our time. I think that's a great point to make sure we support each other, check in with each other, no matter where we are. I wholeheartedly support asking all of our colleagues, how are you?
Yep. We all have to practice self-care.
So with our question and answer time, we have a president's corner. If Alan, if you wanted to address one of the questions.
Sure. Sorry, I was just. Do you have any? I'm sorry. I just turned off something. Is there a question?
No, I just I thought you had wanted to answer one of the questions I saw in a comment earlier.
Oh, I think.
Make sure to give you the opportunity. If you already answered it, then we can pick out some questions before we close. There's only 16.
I think it has been answered, and I think that Sarah sort of reiterated so many great resources on the chat as well. And I was sort of at the same time trying to screenshot and copy those things. So thank you everyone for a wonderful presentation and wonderful resources. It's so heartwarming to know there's so many of you there in the trenches and trying to do the best we can, teaching one another these wonderful things, and just got to keep it together. And that self-care is so important. I did want to see if one of our special guests was here. Courtney, do you know if Rick is online?
I think I saw him.
I am checking. Oh, I think he's gone.
Oh, okay. Well, Rick's been online and he's such a wonderful resource. If everyone has not heard, he was recently appointed to the President's National Council on Disability. So he's always there for you all as well. Great resource for DSP, great resource for every one of us, and feel free to contact him. So another advocate for us to utilize. So thank you again for everyone. Wonderful program tonight. Thank you, Ben, for helping moderate.
Sure. So and I'm happy to, and we have some time for questions. So is everyone able to see the questions that came in? There's 16 open questions. If anyone would like to, or some of them are comments. There were some questions about joining DDNA, and I'm hopeful that that those can be addressed on the DDNA website. And there was a question that it looks like we addressed on training and skill building, helping nurses interact with fear among staff, as you guys had pointed out. If you had any suggestions for that, and then there were some. It looks like you guys addressed a lot of the questions that are there. So we have some additional time, finishing up just a bit early, unless Sarah, unless you'd like to offer some closing thoughts.
Well, sure. And I was noting there was the question about fear among staff, which I thought Chris answered so well about sometimes you just have to get into the trenches with the staff. And I think, which leads me into a point of having talked to some of the community agencies here in Illinois, that I've heard comments that sort of if there is one, any silver lining around COVID is that it's put more attention in general from staff and the frontline staff and others in the agencies towards the health of their clients, and and certainly has put more focus on the role that nurses have in trying to lead managing COVID itself, and then trying to manage wellness in the face of COVID. Because there's more attention to both health overall and managing diseases, as well as managing health in the context of disease, that we really need to grab a hold of those things and not lose it. And that's part of also that the world won't be different. It'll be different when we go forward. It's not going to go back to just quote normal. It'll be different. And some of those differences, like utilizing telehealth, utilizing educational design, these kinds of things, they're not going away, and we need to grab hold of them and lead them. Is kind of my ending thought, I guess.
All right.
And I see one question here that just says the direct support professionals have done an incredible job taking care of our individuals. How do we recognize and support all the IDD nurses who work every day, often alone? And
Right.
The person said, I think one way I know would be to encourage all nurses to join DDNA as a way of being supported by employers. And I have to say I agree completely. And DDNA is a wonderful family of nurses, and I hope that employers out there, in terms of how can they support nurses, one way would be to help by having them belong to DDNA so that they have access to resources. And one of the things that that being a DD nurse and having some experience offers is what I call that priceless commodity of experience. And being able to talk to another nurse who knows what it takes to do what you do every day is really an unbelievable moving experience sometimes. And the only place you get that, quite frankly, in mass is at DDNA. So I welcome anyone to join DDNA, and I hope employers will consider that as a way of supporting their nurses as well.
And I would say also, this is Sarah, that for agencies, if they haven't already brought nurses into their leadership team, they should think about doing it, because I think we bring a lot to the table.
Yep.
As to how to manage both COVID itself and trying to be well in the face of COVID.
Yeah. No, I think that's an excellent point. I think sometimes administrators or managers, especially if they've not been around a long time, they may view nurses as just real task-oriented members of the team. We come in and we do medications, or we come in and we do an assessment, or we quote do delegation. That's a whole other topic for a whole other day. But the point is that I think sometimes they don't see us as really the resource that we are, and we should be included in those administrative teams, just to try to help guide. And one of the things we talk about is diversity of thought being so important, and diversity of perspective being so important. And a nurse does bring a unique perspective. Sometimes you wish they'd be quiet and maybe not have such a perspective, but they bring a very valuable perspective. And I think I think it would behoove any program out there to make sure they include those nurses in those leadership meetings when you're trying to develop a direction or trying to address a problem. And certainly something as complex as COVID-19, they should be right in the middle of that. So thank you, Sarah. I agree.
And I would just like to say, all of us are in this field because we're passionate about it. And I want to thank all of you who dialed into this meeting tonight for all that you're doing.
And I just want to say that at one time I was Wendy's graduate student, so I'm so happy to be on a panel with you, Wendy.
Well, thank you, Sarah. And I'm getting ready to retire.
Well, I just got a 5-year grant and I'm not.
Yeah.
Well, congratulations, Wendy, on your future retirement. And Sarah, I'm glad you're sticking around.
Yes.
Ben, I just wanted to extend a thank you to everyone that participated on our webinar tonight and gave us their time. I think that right now that's a pretty valuable commodity, and we don't necessarily have enough of that. And I can't thank AADMD enough for inviting me to participate as a panelist tonight. I don't know that that was top on my list of things to do, but I really kind of embraced the challenge, and you know, I again appreciate this opportunity. So thank you.
Really want to thank AADMD for organizing this.
Me too.
Yes, I do as well. And I thank my fellow panelists so much for all of your words of wisdom. And I'm sure that people got a lot out of that. So thank you guys. Thank you for including me, and thank you AADMD for coordinating all of this and making this available. We really appreciate it.
Well, I just wanted to say thank you guys from AADMD, and I know Alan already did thank you, but you guys were troopers. You hung in there. You were so informative. This will all be recorded and available on our website to view later. So anyway, thank you guys so much. Ben, I'll let you wrap it up.
Thank you. I just wanted to again thank our wonderful panelists for joining, for teaming up with AADMD. Want to make sure that when everyone is done joining DDNA, that they re-up their AADMD memberships as well, in addition to or join for the first time. Welcome. We of course you know, as essential as nurses are, we want to make sure that there's a strong nursing voice at AADMD as well. And just wanted to hold on to the idea and plant the seed of remembering, just like the panelists were saying, that the leadership role that nursing has been able to demonstrate, and nursing has stepped up to provide in bridging the medical needs of these of the individuals we care for to on the ground applied policies and care has been so invaluable. And I think the shining work that's been done over the past 8 months, I hope will be continuing going forward as nursing holds on to that role. So that's pretty much it. Just want to thank our nurse colleagues and appreciate the leadership and appreciate the ongoing care. So with that, I wanted to as well say there's a couple questions that we'll take note of, and maybe contact people offline who had some excellent questions about person-centered paternalism versus autonomy problems that we weren't able to get to. But keep an eye on statements coming from AADMD. And there are resources out there. We can reach out after the conference. And there were some questions about staffing that we'll make sure to distribute, problems of staffing and coping that we didn't get to. But please do know we really appreciate those great questions. So we'll take note. I took note of who asked them, and we'll try and contact you offline. Thank you so much.
Thank you. Good night, everyone.
Thank you, Dan. Good night, everyone. Bye-bye.
Thank you.